So this is going to be part 2 of task 6. We're going to talk about the different reflexes and how they pertain to the depth of our anesthetic plane, or our anesthetic plane and the depth of the anesthesia in our patient. The first one that I wanted to usually talk about is usually the first one to go. You usually see disappearance of the pedal drawback. You're going to usually see that at the stage 1, stage 2 of anesthesia. Stage 1 is kind of like our induction, where the dog might have a little bit of analgesic, and it's kind of like an excited phase. Stage 2, that's going to be when they're going to kind of be going down a little bit faster. You'll see irregular heartbeat, you'll see irregular respiration rate as they're kind of settling into an anesthetic plane of around a stage 3, or say 3, like stage 1. So that's where we usually start. So usually the pedal reflex disappears at about stage 1, stage 2, and then we'll follow that up with the ear flick reflex. That's usually the next one to go. That one's up here, and so we usually put our finger right here in like the crest of their ear, just to see whether or not they'll see any twinging or twitching. That usually disappears in plane 1 of stage 3. And then we also have the palpebral. And if we look at our little guy here, this would be done just by, oh, he's pretty blue eyes. This would be done just by hitting the corner of the eyeball. And if they still have a blink reflex, we know they're pretty light. And that's also going to go into play with the position of the eyeballs. Sometimes the eyeballs, once they get into the deeper anesthetic planes, they'll roll down. And if they get too deep, then they'll actually come back up and be staring forward, and you'll lose all light reflex as well. So we have the palpebral, discuss the pedal, discuss the ear flick, and then the corneal reflex. That's the one where we have our light reflex, where if we shine the light into the eyes, we'll still get dilation or constriction. That usually disappears right about stage 3, part 3, and stage 3, plane 3, rather, sorry. And that, once they get too deep, if they get into the stage 4, that's usually when they can get a little bit of the respiratory depression. And then stage 5, or stage 4 and stage 5, that's just really too deep for anything that we want to do. We like to keep our surgical patients in that stage 3, in the second to third plane, in the first and second plane. The first plane for light anesthesia, second plane for any major procedure. For the next one, we also want to talk about our jaw tone. So when we do jaw tone, that's something that's also really important. We want to make sure that we have good muscle relaxation. So if it's really hard to open their mouth, using just our fingers, not forcing the mouth open, of course, then we know that we're still going to be a little bit too light. And if it's nice and easy to open the mouth, then we know that we're kind of in a good spot. Oh, excuse me. And then the last one is going to be the reflex. We generally look at our jaw reflex, our laryngeal reflex upon intubation, and that's going to be the swallow reflex that we generally have. And that's lost early in stage 2, and that's where we're able to intubate the patient. The next one, I already discussed the respiratory patterns. With the respiratory pattern, like I said, in stage 2, it's pretty erratic, just like the heartbeat as they're kind of getting settled. Everything's still a little bit excitatory at that point. But those are just the things that we monitor with these guys. We'll be back for stage part 3.